EMA criteria and FDA criteria in comparison to 3.5 months with the physician choice regimens with very impressive hazard ratio of 0.27 to 0.32 and very clear separation of the curves in the Kaplan-Meier curve. And I would like to take your attention only on the peripheral sensory neuropathy, which was 5% here, grade 3 and more in the brentuximab vedotin versus 0% with the physician choice. And this is explained by the fact how the drug works actually. So it is a drug antibody conjugate, which actually works by binding with the CD30, and then the active moiety is internalized, which does the microtubule disruption. And the other toxicities were quite similar, except there were skin infections were a little bit more with the bexarotene in comparison to brentuximab. Now, moving to the mogamulizumab, the role of mogamulizumab in the CDCL. So it is approved by US FDA and EMA for adult patients diagnosed with mycosis fungoides or the Sézary syndrome as a second line or subsequent line of treatment options who have received at least one prior line of systemic therapy. So this is how the drug actually works. So this one you can see this is a malignant T cell, and then this is chemokine receptor 4, and the chemokine receptor 4 are expressed on the malignant T cells, and the mogamulizumab is actually first in class antibody which is targeting this chemokine receptor 4. So as soon as mogamulizumab binds with the chemokine receptor 4 expressed on the malignant T cells, it produces a bridge between the malignant T cell and the immune effector cells, which actually releases the granule that destroys the tumor cells. So this is the summary of the recommendation for the use of mogamulizumab for Sézary syndrome and mycosis fungoides from EORTC 2023 and NCCN 2025. Just to recap and refresh the memories, the mogamulizumab is recommended as a second-line treatment option for the mycosis fungoides stage 1A, 1B, and 2A. It is recommended as a first-line treatment option for the mycosis fungoides stage 2B, 3A, 3B, 4A. However, for the stage 4B, the patient should have received at least one systemic therapy before. And this is recommended as second-line treatment option for the Sézary syndrome. And in NCCN guideline, mogamulizumab is recommended as a preferred regimen in NCCN guideline, right from the mycosis fungoides stage 1B up until Sézary syndrome stage 4A1 and stage 4A2. Now, the second landmark trial, which I promised with you that I would be sharing with you, is the Maverick trial, which evaluated the safety and effectiveness of mogamulizumab, the first-in-class antibody targeting chemokine receptor 4 expressed on the T cells. So this was an international open-label randomized phase 3 trial, and this is the study design of the Maverick trial. So there were 372 patients, although this disease is rare and mogamulizumab is an orphan drug. However, in this study, we have seen enrollment of 372 patients, which is very big and significant number. As Dr. Badri mentioned, that this disease is quite rare. So 372 patients is a very big and significant number. So the patients who were diagnosed with the stage 1B, 4 up to 4B, with histologically confirmed mycosis fungoides, that's Sézary syndrome, were enrolled in the trial, and the patient should have received at least one prior systemic therapy, and they should have the good performance status. The patient, those who had large cell transformation, they were excluded from the trial. Similarly, the patients who had received mogamulizumab or golimumab, they were actually excluded from the trial. And the patients who received skin-directed therapy within 2 weeks and the systemic therapy within the 4 weeks period, they were also excluded from the trial, as the washout period recommends the skin-directed therapy to be more than 2 weeks and the systemic therapy to be more than 4 weeks. And patients with CNS metastasis were also excluded. So the 372 patients, they were randomized to receive in the intervention arm mogamulizumab 1 milligram per kg over 1 hour infusion, on day 1, 8, 15, 22 in induction, which is 4 doses. And after that, the dose was given every 2 weeks in a 28 days patient until the disease progression or unacceptable toxicity. And the control population received a vorinostat 186 patient, 400 milligram daily in 28-day cycle until the disease progression or unacceptable toxicity. And one-way crossover after the disease progression was allowed. And in the previous Alcanza trial, we had seen that CD30 positive expression was requirement for participation in the clinical trial. However, in Maverick trial, the chemokine receptor 4 or CCR4 expression is not a requirement for participation in the Maverick trial. So here we have the endpoints. So the primary endpoint is investigator-assessed regression-free survival. Secondary endpoints are overall response rates, duration of response, patient-reported assessment of quality of life. This is one of the most important outcome of oncology patients in general these days, and overall response rates in crossover population, safety, and immunogenicity. So here is the primary endpoint that you can see that mogamulizumab had been a hands-down winner over vorinostat. You can see the Kaplan-Meier curve started separating right 2 weeks after the start of the mogamulizumab in vorinostat, and curve goes all the way being separated. And you can see the PFS is more than double. It's 7.7 months versus 3 months. So it's more than double, and the hazard ratio is 0.53. And any hazard ratio which is less than 0.65, and improvement in the PFS is more than 3 months, then in the European Society of American Oncology magnitude of clinical benefit scale, which I did not put it here, the score is usually 3. And if the quality of life, which I'll be sharing with you, is also improved, then this score is 4 or 5, which is really a substantial benefit of use of these drugs. And definitely this kind of improvement in progression-free survival, doubling the progression-free survival, addresses the unmet medical need in the management of these patients living with debilitating symptoms. And the mogamulizumab is really an unmet medical need. It's an orphan drug, but it's an unmet medical need for the management of these kind of patients. And then here another secondary endpoint, which is the time to next treatment intervention, was more than 3 times increased, 11 months in mogamulizumab versus 3.5 months in vorinostat, and clear separation of the curves again. The other effectiveness outcomes is the overall response rate or objective response rate in IDD population was 28% in mogamulizumab versus 5 months in vorinostat. So it's more than 5 times increased. I'm going to show you the breakdown of this for the different CTCL subtype. And so in general, mogamulizumab did better in comparison to vorinostat with regards to overall response rate and median duration of response for all CTCL subtype, including mycosis fungoides and Sézary syndrome, as well as all stages of the disease. We'll breaking it down, and we'll be discussing in different slides. So here is again, just to recap, overall response rates for mogamulizumab in intention to treat population was 28% versus 5% in vorinostat, and duration of months, median duration of months for mogamulizumab in ITT population is significantly longer, 14 months versus 9 months in vorinostat. And now let's have the review of the overall response rates and the duration of response for the different compartments. So in skin compartment, overall response rates were 42% for the MOGA versus 15% for the vorinostat. So it's almost 3 times increased. And duration of response in the skin compartment is about 21 months in the MOGA versus 11 months for the vorinostat, almost doubled. And in the blood compartment, we have seen significantly pronounced activity of the mogamulizumab. So the overall response rates are 67% in the MOGA arm versus 18%, so more than 3 times increased here. And also the length of the response and the duration of the response was significantly longer in the blood compartment, almost 26 months. And in the lymph nodes, the overall response rates were about 15% versus 4%, almost 4 times increased, and the duration of response was about 15 and a half months. And in viscera, there were no responses. So now moving to the different CTCL subtype. So in mycosis fungoides, overall response rates were 21% versus 7% in the vorinostat, so more than 3 times, almost 3 times increased. And in Sézary syndrome, the overall response rates were much higher, 37% versus 2%. So it's 18 times increased, or 1800% increased in the patient who received mogamulizumab. And the duration of response in mycosis fungoides was 13 months in the MOGA versus 9 months in the vorinostat. And for the Sézary syndrome, duration of response was 17 months in the MOGA versus 7 months in the vorinostat. And this is the most important outcome, which most of the randomized control trial are including now as a patient-reported outcome and health quality of life. Really tells us how effectively, for example, if we improve the progression-free survival and overall survival of the patient, but the only clinically meaningful survivorship will be if there is a clinically meaningful improvement in health quality of life. So Maverick trial looked at quality of life aspect, and they have shown that the time to clinically meaningful worsening using the Skindex 29 was has significantly favored mogamulizumab over the vorinostat. And so this drug has not only improved and doubled the progression-free survival and 5 times increased the overall response rates, but also has improved the patient's symptoms and well-being of the patients. And median time to the symptoms worsening was 27 months for the MOGA versus 6 months for the vorinostat, so more than 4 times increased. And significantly less number of patients in the mogamulizumab had clinically meaningful decline in the physical well-being, which is 13% versus 43%, and significantly a big proportion of patients, around 84% of patients, they had reported clinically meaningful improvement in the symptoms who
السلام
received
عليكم دكتور،
mogamulizumab
كيف حالك؟ عساك اليوم
versus
بسلامة وخير.
vorinostat,
دكتور اليوم
which
كان
is
عندي مشكل في رجلي.
50%.
طبعا خلاص احنا ماشيين
And
في الامتحانات
with
وغادي
regards to
نختبر.
the
بس
safety,
اقدر بس نعطي استفاره،
treatment,
وطبعا
emergent
خلاص احنا
adverse
ماشيين في
event,
هذيك
and
الابروف
grade
وكل
3 and
حاجه،
more
موضوع الوصفات
toxicities
صح؟
and treatment leading to
ننتظر بس نعطي
discontinuation, they were
الاستفاره
quite
وبعدين خلاص
similar
نبدا معاكم.
between the two
في
groups.
حاجه
Although
صراحه حلوه صارت
treatment,
اليوم
emergent
وما
adverse event
ادري
leading to
رايك. في
discontinuation were
شركه متواصله مع
numerically a
مشرفتي
little bit
قايلين
more
لها
with the
انه
vorinostat.
عندنا ماجنت كارديولوجي اللي هو ام سي
So
جي.
here is the commonly
ف
reported treatment-related adverse event who were seen in 20% or more than 20% of patients in either group. So the blue bar is representing mogamulizumab, and the gray is representing vorinostat. So here we can see infusion-related reaction and drug reduction is more common with the mogamulizumab being 33 and 24% in comparison to 1% with the vorinostat. However, fortunately, the most significant side effect is grade 3 or more as per CTC AE version 5 was only 2% in the mogamulizumab, and drug reduction was only 4% grade 3 and more. Whereas all other toxicities, diarrhea, fatigue, nausea, thrombocytopenia, decreased appetite, and many other side effects were significantly higher in vorinostat in comparison to mogamulizumab. This is again the summary of all grade toxicities and grade 3 and more toxicities. So it's just the repetition of the previous slides. So infusion-related reaction and drug reduction is more commonly seen with mogamulizumab in comparison to vorinostat, and all of the toxicities are more commonly seen with vorinostat in comparison to mogamulizumab. So this is the conclusion and the summary of the Maverick trial. So we have seen the primary outcome, which is the PFS, is actually more than doubled. Uh, uh, with the mogamulizumab. So it was almost 8 months versus 3 months, and objective response rates were significantly higher. In intention to treat population almost increased by 5 times, and we had seen pronounced activity of the mogamulizumab in the blood compartment. And I like this trial because of the fact that it has reported patient-reported outcome, and it has reported the healthier quality of life using the skin DAX-29, which has shown significantly better and improved healthier quality of life, which makes the use of the drug clinically more meaningful. And the drug was tolerated very well. It has had manageable safety profile. And just to refresh your memories, we discussed the dosing, but here this slide actually addresses the doses and the schedule. So it's 1 milligram per kg, given over 1 hour. So and it's supplied as 20 milligram vial. So a patient who is like 60 kg, his dose will be like 60 milligram, day 1, day 8, 15, and 22 in the induction. And then consolidation is given every 15 days in 28 days fashion, and the drug is continued until the disease progression or unacceptable toxicity. So there are some real-world evidence studies which has shown overall response rate or objective response rates in the range of 60 to 75%, which is quite impressive. With this, thank you so much, and I can leave my email address here for any questions and concern. And thank you so
Thank
much.
you very much, Dr. Mansoor Khan. As usual, your presentations are very well received, very rich presentations, and you made it really crystal clear. Thank you very much. Today we have around 6 questions, 3 questions to each of our distinguished speakers. Allow me, Dr. Mansoor, to start with the first questions addressed to you. As you know, and as you've mentioned, the cutaneous T-cell lymphoma is a rare disease, and the drugs that are used for this rare disease are majority are orphan drugs, and the procurement, as you know, is a dilemma, and often it's a difficult process. So, how to address this unmet medication need to improve the accessibility of those medications to our debilitating or to our patient with this debilitating disease?
Thank you, Dr. Sama. I think it's a $1 million question. So it's a rare disease, as mentioned by Dr. El Badri. And mogamulizumab is an orphan drug, to be honest with you. And it's an unmet medical need to manage this patient in subsequent lines of therapy, living with debilitating symptoms of mycosis fungoides and Sézary syndrome. And it's really a big dilemma. The drug is approved by Saudi FDA, and I'm sure that it's approved by other countries as well. However, because of the rarity of the disease, it's not added to the formulary in the institution. So then the procurement and the supply chain becomes an issue, as if you are using it on non-formulary basis, so supply chain is interrupted, and these patients, they really suffer a lot. So one of my suggestions, I have actually 2 suggestions to address and tackle this issue. One of them is to have a national body to deal with rare diseases and orphan drugs, and because this national body can review the evidence and can look at the loopholes, how to procure the medication, how to maintain the supply chain. And at the same time, if the drug can be added to institutional formulary, then you can try to estimate number of patients, but it's pretty difficult to estimate the number of patients as well. So sometimes what happens, as Dr. Badri mentioned, they have 6 patients. So we used to have 5 patients in Jeddah, 5 patients in Riyadh. But sometimes if the drug is available and the patient, they have an idea that the drug is available here or other institution, they can refer more patient to your center. So then you can probably have a good idea of your anticipation or estimation. So sometimes what you do, like you overestimate and you don't have enough patient. And sometimes you underestimate and you have more patients. So this is always a dilemma. So for that reason, I think if you have a national body who can actually collaborate with each other and look at the scientific evidence, as well as the supply chain issues can be addressed, as well as it should be into the institutional formulary. I think the tertiary care center, they should add this drug to the formulary. I think adding the drug to the formulary can address so many issues of the procurement and supply chain.
Excellent. Dr. Abdullah, would you like to add anything to what already mentioned by Dr. Khan?
Wallah, Dr. Khan, I'm total agree with Dr. Mansoor what he said about the medication for such patient. بصراحة أنا يعني full respect Dr. Mansoor for the presentation and for this comment.
Excellent. First question, Dr. Abdullah, how important is the blood assessment through flow cytometry and its importance on prognosis of cutaneous T-cell lymphoma?
Okay, very important, Doctor. Very important questions. Okay, because the blood assessment is very important. Why? Because the blood can be involved even in the early stage of the disease. In the fact, one study showed, I read it, okay, that roughly 1 in 5 patients of early stage mycosis fungoides have T1, okay, blood involvement, and this blood involvement, okay, had poor prognosis and poor outcomes. That for this reason, I recommend the doing flow cytometry at the diagnosis, and when we have clinical red flags. For example, when we have patient with intense pruritus, when we have patient with lymphocytosis in white blood cells, patient with erythrodermy and high level of LDH, and patient lack of response of the usual modality of the treatment, and in the advanced disease, okay, stage 2B and above. That is very important to do flow cytometry for such patient.
That's excellent. In this context, we have a question from Dr. Hussein Shamrani. So, if the patient T1 only skin, he's on phototherapy and topical, then skin is resolved. Do we continue phototherapy or not?
Very important. Okay, don't stop the therapy of UVB light therapy after clearance of the skin. Those patients after stopping of the light therapy have high risk to relapse. Okay, again, for my patient, I recommend to stay on the maintenance therapy. That means after you start with 3 times per week, after resolve of the skin, okay, lesion, you can stay on maintenance 2 times per week for 1 to 6 months, or once weekly for 1 to 6 months. Don't stop, okay, immediately the light therapy. Something to mention also, the patient with patch type mycosis fungoides may benefit of UVB, narrowband UVB light therapy, and the black type of mycosis fungoides may benefit of UVA light therapy because the penetration of the waves in this lesion.
I see. And this, also in this context, Dr. Hussein is asking if patient was on UVB phototherapy and topical, then skin resolved. So he's asking about the
It's the same.
continuation of phototherapy.
Yeah, maintenance therapy. Don't stop the the light therapy immediately.
Excellent. Dr. Fadia Hassan is asking for how long we use SDT, then we shift to systemic therapy, Dr. Mansoor and Dr. Abdullah, if you have any answer on this.
Dr. Mansoor, what is your opinion?
Sorry. If you can repeat the question, sorry, I was.
For how long we use the SDT before shifting to systemic therapy?
You mean like local therapy before
Yeah.
shifting to systemic therapy?
Yeah.
I think if the disease is localized, that does not need the systemic therapy. You stay on the local skin-directed therapy, and you should just continue. But if the disease is requiring systemic therapy, then you can choose the combination of skin-directed therapy and the systemic therapy. So it depends on the disease area involved. So I think Dr. Al-Badri already mentioned this.
Okay. Dr. Abdullah, Saleh Al-Zahra is asking, probably you addressed this in your presentation, but let's re-emphasize about the common symptoms of cutaneous lymphoma and what are the key elements in its diagnosis.
Okay, the most common symptoms, if you ask about the symptoms, is intense pruritus, okay, in the patch form of mycosis fungoides. You have patch, okay, with severe itching that increase with persistent of the treatment modality that increase and raise our suspicion of mycosis fungoides. How
Excellent.
can we diagnose? Okay, simple. Okay, take biopsy from the center of the lesion. Okay, send for histo and immune histo phenotyping.
That's amazing. Dr. Khan, we have Dr. Marwa Ahmed is asking, with mogamulizumab and brentuximab showing remarkable results in trials, how should clinicians in resource-limited settings prioritize or integrate these therapies into treatment plans where access may be restricted?
So this is a dilemma, if you're talking about the resourceful countries, just Saudi Arabia, Qatar, Kuwait, UAE, I think it's not an issue, but resource-limited countries, this is an issue. So I think their drug registering authorities or drug, regulatory authorities, they are the one who should deal with this kind of situation with regards to the pricing, and what number is the threshold for the cost effectiveness with regards to the ICER. So usually WHO times three of the GDP is considered acceptable threshold for approving drugs in this kind of category, which in the resource limited country might not reach. But I think the regulatory authorities of the countries probably can address this. It's beyond my scope actually right now.
Excellent. I'm surprised that we are, until last moment, we have a gathering. We are a gathering of more than 1,200 clinicians today. That's amazing. A question also by Dr. Ahmed, Dr. Marwa Ahmed, very interesting questions. First, she said with cutaneous T-cell lymphoma being rare but often misdiagnosed, do you think there is a need for mandatory training or diagnostic algorithm in general dermatology clinics?
Yes, Marwa Ahmed, I'm agree because this a rare disease, but we face it in our clinic. Okay, what I do, and because I'm the head of department, if we have patient, okay, with mycosis fungoides, we meet even okay a meeting, okay, and we will talk about the differential diagnosis and how can we diagnose this patient. Okay, training, increase awareness, lecture from the company. I think all that help each other to learn about the mycosis. As I said, is very mimicker disease. Okay, the diagnosis is very challenging. Okay, need training, need to see the patient of confirming cases. Okay, need a lot of effort to reach the diagnosis.
And in this context, Dr. Abdullah, Dr. Marwa is asking how to expedite early detection, especially in patients with skin of color, to
I think
prevent and
is
reduce the chance of misdiagnosis.
this is misleading, okay, because this patient of skin of color, okay, represent with the erythema, but we can see the erythema because of skin of the color. Okay, what is the guidance? These itching, severe itching, okay, for those patients in non-sun exposed area not responding to the modalities, the usual modality of the treatment of atopic dermatitis. I think, okay, we make a biopsy, okay, for save the time for safety of the patient. Take biopsy is the key point for those patients if you have 1% suspicion of the mycosis fungoides.
Excellent. Dr. Aya Abdulatif is really thanking you for very rich, fruitful presentations today. Her case was a female who was 36 years old with T4 lesion. Asked for CTS, but in your opinion, which protocol would be preferred?
Dr. Mansour.
Dr. Mansour, advances in treatment is your area.
So T4 is an advanced disease, right? So it
Yeah.
involves a lot of areas. So I think here is NCCN guidelines recommends to use skin-directed therapy, local therapy, plus systemic therapy. So I think T4, so the lymph nodes are not involved, right?
It doesn't say.
So Dr. El-Badri, so do you agree like T4 is an advanced disease?
Advanced
So
disease.
yeah,
End stage. Yeah.
so
Advanced.
it needs local therapy plus systemic therapy.
Yes. Absolutely yes.
Excellent. Let's take the last question by Christine Martinez. First, she's thanking you for this very informative webinar. And she says, as discussed, MF has high incidence in black skin individuals. So do you think the use of internationally approved glutathione supplement injection, which is known for its antioxidant and skin lightening effect, may help in the prevention of its occurrence?
No. The answer is no. There is no study for giving those patients to prevent the mycosis fungoides of skin of color. There is no study for it.
So it's an
No.
absolute no. So allow me to end my the session today by a note by Dania Al-Mahi. That was very nice presentations. Thank you very much, Dr. Mansoor Khan. Thank you very much, Dr. Abdullah Al-Badri. And we hope to see you at IVPN more and more in the near future, inshallah.
Thank you.
And now, أهلا وسهلا. I leave the stage for Dr. Ahmed Laweni for an interesting and fun Kahoot game. أهلا وسهلا, Dr. Ahmed. I will leave the mic and the stage and the screen for you.
Assalamu alaikum wa rahmatullah. Masa al-khair. Thank you, Dr. Osama, for the great engaging moderation. And thanks to all the speakers and Dr. Abdullah and Dr. Mansoor. And now it's the time for the Kahoot. So I will be sharing now the Kahoot link so that everyone can join. Today's Kahoot will be 6 questions, 3 from each presentation. So I kindly ask the audience to check the chat. I'm sending now the link. So now it's sent. So if you click on that link, you can immediately join the Kahoot. So I'll be sharing the screen now. Good. Yeah, I can see Lean. Oh, mashallah, more than 1,200 attendees are still until this moment. This is impressive. Very interesting topic today. It's not that common disease and orphan drugs we learned about. So I see many familiar names here. We will start the Kahoot in 30 seconds. I encourage everyone to join us. Fun and healthy competition game. You have to be fast and quick and accurate in answering. Those who win the Kahoot, the top 3 winners will be featured on our platforms that are followed by thousands of healthcare professionals in the region.
Go, Dr. Ahmed. Yalla.
Yalla, bismillah. 1, 2, 3. Here we go. So, our IVP in cutaneous T-cell lymphoma, and our first question from Dr. Abdullah presentation: what is the most common subtype of cutaneous T-cell lymphoma? So it is, as majority of you answered, mycosis fungoides, and for that we see Fatin is in the beginning. Moving forward, what is the only curative treatment of cutaneous T-cell lymphoma? It's allogenic stem cell transplant as the definitive and curative treatment. And the scoreboard completely shifted. Mariam now is in the first place. Nujud, Hejo, we have, we always encourage everyone to write their full name so that we can, communicate with you later. And the third question also from Dr. Abdullah presentation, which of the following factors contribute to delayed diagnosis of mycosis, fungoides, especially in those with darker skin tones? Yes, erythema presents differently and is harder to detect. So when that is there, this would contribute to the delayed diagnosis in those subset of patients. And Mariam retaining, Marwa Ahmed is now in the second. She came from outside the scoreboard. This is very promising. So we are survival compared to physician choice in Alcanza trial. So yes, majority of you went for the correct answer, which is brentuximab vedotin. And Mariam in the beginning, very close, Marwa, and Hadil Yusuf now in the fifth place. Moving forward, what is the primary mechanism of action of mogamulizumab? So as Dr. Mansoor mentioned, it basically induces ADCC by targeting CCR4 on tumor cells. And the same top two still, RJ is in the third place now. The last question, either Mariam or Marwa will get it. Which of the following was a significant finding from the Maverick trial that tested for mogamulizumab? What was the main benefit there? Definitely to improve the quality of life and the symptomatic control. So with that, we come to the podium. In the third place, we have M2. Second place, we have Marwa Ahmad. And the first, I guess it's Mariam. Yes, congratulations to the top three winners, Mariam, Marwa, and M2, Hadil and RJ in the runners-up. Congratulations to everyone who participated. We hope it was a beneficial Kahoot and fun as